أبدأ يا دكتور إسلام. دكتور إسلام.
ايوه دكتور عبد الله، معاك ثانية واحدة. about to finish. اتفضل. لحظة واحدة يا دكتور عبد الله، ثانية واحدة. ايوه دكتور عبد الله، السلام عليكم، سامعني دلوقتي؟
كويس.
طيب احنا هنبدأ. اقدم حضرتك بس.
بعض الناس عندهم مشاكل في الدخول، يبقى يشوف اللي عنده حاجة يبدأ عليها.
بنعتذر على حكايه الرقم الغرفه ده، والرقم الجديد هو اللي شيره الدكتور ثري دلوقتي 343002208. We'll try to solve this problem.
هو الرقم اتغير ولا ايه يا دكتور إسلام؟ دكتور أحمد؟
لا مفيش حاجة اتغيرت.
امال ليه دخلوا على حاجة مختلفة؟
احنا دلوقتي لايف دكتور عبد الله.
أبدأ.
بس أقدم حضرتك. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. النهاردة بنبدأ محاضرتنا مع اونلاين اوفسا مع استاذنا الدكتور عبد الله المنيسي. دكتور عبد الله المنيسي is an eminent neuro-ophthalmology consultant in Dahran Eye Specialist Hospital in Dahran, Saudi Arabia. He is one of the eminent names in neuro-ophthalmology in the Middle East and in Saudi Arabia. So we are welcome Dr. Abdullah al-Menisi. تفضل دكتور عبد الله.
Thank you, Dr. Islam, and thank you for inviting me to share my presentation in this group. I will talk about optic disc swelling from the clinical point of view. As you know that the optic disc swelling is not uncommon presentation in our practice, so it is very important to master to know the important features of swollen disc, normal disc, and apparently swollen disc. So this is what we will talk about, inshallah, in this presentation. The optic nerve head is a flat disc with a central depression or cup of variable width and depth. This is the cup. It measures 1.5 by 2 millimeters, and the mean cup disc ratio is about 0.3 or 34 millimeters. The retinal axons bend 90 degrees posteriorly over the scleral disc margin to pass through the lamina precorsum. Normal optic disc is pink in color with well-defined edge. The cup is present. The vessels shows normal pattern in calipers. Pattern lines are not seen or absent because this is a characteristic of optic disc swelling or disc edema. Nerve fiber layer is transparent around the optic nerve or optic disc. The hemorrhage or exudate is absent. Venous pulsation is present in about 80% of normal people and may be absent also in about 20% of people. What about swollen optic disc? Swollen disc is hyperemic or pale in color with ill-defined edges. The cup is filled or absent. The vessel showed abnormal pattern and caliber, may be dilated or tortuous. Pattern lines are present in epithecal edema. I'll show you the picture. Nerve fiber layer is opaque around the optic disc. There is opacification of peripapillary nerve fiber layer. Hemorrhage may be present or exudate also. Venous pulsation is absent in papillary edema. If you have a patient with bilateral optic disc swelling and you can see venous pulsation, so this is not a papilledema. Here, this is the normal disc, pink in color. The temporal side is lightly paler than the nasal side. This is normal finding. And this is hyperemic disc, and this is pale disc. So the color of the disc is important. Examine the disc or the color of the disc. We can tell about the color by examination, by fundus examination, not from pictures. Because a picture may be overexposed and the disc may appear pale, while it is normal. So examine the fundus and see if the disc is hyperemic or pale and compare both eyes. This is very important. Edge. This is ill-defined edge. And this is early swelling, ill-defined edge nasally in early papilledema. As you know, the papilledema starts nasally, the disc, and then in the upper and lower pores, and then total swelling or blurring of the margin of the disc. The cup is filled.
دكتور عبد الله استاذنك الصوت مش واضح قوي. لو حضرتك تقدر انت بتتكلم من الكمبيوتر ولا
من الكمبيوتر تستعمل سماعه؟
يا ريت تستعمل السماعه بعد اذنك.
This is better.
better. الحمد لله كويس جدا. اتفضل دكتور عبد الله. We just told Dr. Abdullah to start with head. It's not something initialized in the noise cancellation.
Now it's working.
اتفضل دكتور عبد الله.
طيب. some
activity للنويز كانسليشن هو ده اللي كل شويه هتعمل البوب اب دي.
very annoying. It's not يعني. So this is the mic of the computer. Now it's good or here in the blood vessels, this is the normal disc. The blood vessels will be tortuous, the large blood vessels, and the small blood vessels of the capillaries on the disc are hyperemic, dilated, and telangiectatic. So this causes the red color of the disc. So this is abnormal blood vessels in swollen disc. Pattern lines are concentric lines seen in the temporal area of the disc. These lines are due to displacement of the sensory retina away from the disc due to edema. This is earlier stage before the edema of the nerve fiber layer. So these are pattern line, and this is characteristic or feature of early papillae. And this is a true disc edema. The peripapillary nerve fiber layer is opaque, and how you see this opaque from the color, and also you can test this by small blood vessels emerging or entering the disc. It will obscure at the edge of the disc due to opacification of nerve fiber layer. The peripapillary area may show hemorrhage or exudate sometimes, so this is in a swollen disc. Here, the venous pulsation can be seen at the emerging point of the vein or at the disc margin. If you see the venous pulsation in the swollen disc, so it's not papilledema. So these are the features of optic disc swelling. You may find different patterns or shapes of disc swelling. You may find swollen hyperemic disc with normal blood vessels, swollen hyperemic disc with tortuous vessels and hemorrhage, swollen pale disc with splinter hemorrhages, elevated disc with pigmentation. You may find elevated disc with blurred margin and lumpy appearance of the disc. You may find extensive hemorrhage in the retina with swollen disc. So these are different entities we can see during examination of the fundus. How can we classify or differentiate these conditions? The differential diagnosis of the optic disc swelling lies in three categories or three groups. True elevation of the optic disc, pseudo elevation of the optic disc, and condition associated with optic disc swelling. True elevation of the optic disc, so this could be acquired or congenitally elevated disc. The acquired condition of disc swelling includes optic neuropathies, as optic neuritis, ischemic optic neuropathy, sometimes toxic optic neuropathy, compressive optic neuropathy, also papilledema, optic nerve tumors. The optic nerve tumors could be acquired or also congenital. Congenitally elevated disc as an optic nerve drusen, and this is pseudopapilledema. It is a bilateral condition, and the disc is elevated, but it's not looks healthy, but elevated and lumpy. So this is a congenitally elevated disc, and this is optic disc drusen. Congenitally elevated disc, there is no drusen, but the disc has blurred margin, and this is called congenitally elevated disc. And this is the diagnosis of exclusion. This is normal, vision is normal, everything is normal, but the disc is slightly elevated with blurred margin. Pseudo elevation of the optic disc could be due to hyperemia, tilted hyperopia or hypermetropia, tilted disc, myelinated nerve fibers, and glial vein. These conditions are the disc is totally normal, but looks like elevated disc. So it has blurred margin, but it's normal disc. So this is not a true disc swelling. Conditions associated with optic disc swelling, these are disease of retina and or choroid associated with optic disc swelling. So this is not an optic neuropathy, and this is easy to diagnose as the pathology or the main pathology is seen in the fundus.
دكتور عبد الله استاذنك بس لان الصوت فعلا
A detailed history.
دكتور عبد الله
Age is important because to differentiate between congenital and acquired. Onset of the visual loss, acute or chronic, progressive, regressive, decisive as in optic neuritis or papillitis, progressive as in compressive optic neuropathy with disc swelling. Also, the associated symptoms with visual loss. If you have a patient with disc swelling and with pain with eye movement, so this could be an optic neuritis. If you have optic disc swelling with headache, jaw claudication, and scalp tenderness, this in an old patient, this could be arthritic ischemic optic neuropathy. So this is important to take it is important to take a detailed history from the patient. The examination is important. We start with the visual acuity, color vision, pupil response to light, to rule out afferent defect, confrontation visual field, to rule out central scotoma in optic neuropathies, and also the fundus examination, which is the most important part of the examination. By examining the disc carefully, you can differentiate between different patterns or shapes of optic disc swelling. Investigations include fundus photo at presentation. It is taken once at presentation for documentation and follow-up of the patient. Visual field, automated visual field is important to know the extent of visual loss, and also the pattern of the visual field loss is important to know the cause of disc swelling. If you have a disc swelling with altitudinal defect, so this is could be AION or anterior ischemic optic neuropathy. If you have a disc swelling with central scotoma, so you may have optic neuritis. So this is the pattern, the visual field. We are concerned about two things: the extent of damage and the pattern of damage.
Just excuse us 1 minute. We will just try to fix the sound. احنا بس هنبدأ دلوقتي هنشوف اسمعوا الصوت. لو الصوت واضح هنكمل بالطريقة دي. اتفضل يا دكتور عبد الله.
Evaluation of the patient. We start with the history. History is important because we are concerned about the age, because we can differentiate between congenital disc swelling and acquired disc swelling. Also, the important points in the age, in the history, and the associated symptoms. If you have a patient with disc swelling, with headache, jaw claudication, scalp tenderness, so this could be ischemic optic neuropathy, arthritic ischemic optic neuropathy. If you have a patient with swollen disc with pain with eye movement, so this could be optic neuritis. So the history is important. Then we go to the examination. We start with the visual acuity to check vision, confrontation visual field to see if there is any central scotoma or hemianopia. The pupil examination, and the pupil examination is important to rule out any afferent pupillary defect. The fundus examination is the most important part to differentiate between different patterns or shapes of disc swelling. And then we go to the investigation. We start with the fundus photo. It's done once to document the condition and for follow-up. The visual field is important also. The visual field is important to see the pattern of the visual field loss, because central scotoma means optic neuritis. Altitudinal defect means ischemic optic neuropathy in most cases. And also, we want to know the extent of visual field damage. Echography is important to rule out optic nerve drusen. This is to differentiate between drusen and papilledema. The OCT is important also to measure the nerve fiber layer thickness and differentiate between papilledema and optic neuritis, or papilledema and drusen. Neuroimaging is a very important part to diagnose optic disc swelling. Here we have a patient shows optic disc swelling of the right eye, hyperemic disc, normal disc in the left eye. This is the swollen disc of the left eye, normal right eye. And this is found in a patient in the middle-aged female with acute diminution of vision, pain with eye movement, color vision deficit, and atrophy defect in the left eye. So this could be optic neuritis. What we'll do next, we'll go for visual field. The right eye shows central scotoma, severe depression, very poor vision in this eye, and normal visual field of the other eye. Next step, we order neuroimaging, MRI, orbit and plane with contrast, fat suppression or fat saturation. This T1 with contrast, axial scan show enhancement of the optic nerve, left optic nerve. And also you can see here in the coronal section, enhancement of the left optic nerve. And there is hyper-intense signal in the paraventricular area. This could be MS. So this is a patient with optic neuritis, could be MS. So this patient underwent pulse steroid therapy in our clinic, and we sent the patient to the neurologist to investigate for MS and continue health treatment. We follow up the patient in the clinic concerning vision and visual field. Another patient shows swollen disc, hyperemic, sectoral pallor, and the patient has gradual diminution of vision. There is some headache rather than pain with eye movement. There is atrophy defect and mild color vision deficit. So this could be atypical optic neuritis. What is the difference between typical and atypical optic neuritis? In typical optic neuritis, there is pain with eye movement. The pain will disappear from the second week. Vision will improve after the second week. In atypical, persistent pain, vision will not improve. Papillitis rather than retropalpar optic neuritis. So this is atypical optic neuritis. What is the cause of atypical? There is a long list of differential diagnosis causes of atypical optic neuritis. We send the patient for visual field. Visual field of the right eye shows upper and lower nerve fiber bundle defect, skip fixation, so the vision is relatively good. Left eye, visual field is normal. And then we send the patient for neuroimaging, orbit and brain with contrast, fat suppression. We have here, shows enhancement of the right optic nerve, thickening of the optic nerve sheath, and also in the coronal, there is severe thickening, enhancement of the right optic nerve sheath. So this could be an optic nerve sheath meningioma. The patient presents with mild diminution of vision, not severe diminution of vision, some proptosis. The patient is concerned about proptosis, but we cannot make any intervention as the vision is good. We send the patient for oncology service, and then we follow up with the patient for long period. Another patient, this is the fundus of a patient, shows swollen optic disc, a defined edge. some pallor and splinter hemorrhage, very small area of hemorrhage here. This and the other eye is normal. This is an old patient with acute visual loss. There is headache, some headaches. The patient is diabetic and hypertensive. There is color vision deficit and afropupillary defect. So this could be anterior ischemic optic neuropathy. We send the patient for visual field. Right eye shows lower altitudinal visual field defect and normal left eye. So no need for further investigation or neuroimaging because this is an ischemic optic neuropathy. We will not see anything by neuroimaging. Sometimes you can see some ischemia of the brain, but it's not significant. So we send the patient for the physician for control of his medical condition. This is a patient with bilateral optic disc swelling, as you see here, swollen hyperemic discs, dilated tortuous veins, thinning of the cups, opacification of peripapillary nerve fiber layer. Also, there is a typical or true acquired optic disc swelling. And the patient presents with blurring of vision. Sometimes he has diplopia. He has headache, nausea, and vomiting. He has tinnitus. So this could be papilledema due to high intracranial pressure. So next step, we send the patient to visual field. This visual field shows enlarged blind spots with nerve fiber bundle defect of the left eye. So this is feature of papilledema. And then we send the patient for neuroimaging. He came with this interventricular mass, dilated ventricles, midline shift. So this is brain tumor. So we send the patient to the neurosurgeon and we follow up the patient concerning his vision and visual field. Another patient with bilateral disc swelling, the disc is elevated, no opacification of nerve fiber layer because of the small blood vessels seen at the edge of the disc. There is lumpy appearance of the disc. There's multiple area branches of the optic disc. So these are the features of optic nerve drusen. So this is normal patient with normal vision, no headache, no nausea or vomiting. It's not papilledema. And also we can tell from this picture it's not papilledema because there is no opacification of nerve fiber layer. Sometimes it's difficult to differentiate in the clinic between papilledema and pseudopapilledema or drusen. So we send the patient for ultrasound. This is a simple test to be done. In drusen, it shows hyperechoic shadow or signal in the optic nerve head. So this is characteristic for optic nerve head drusen. And also, if you go to the OCT, we can see thinning of the nerve fiber layer instead of thickening of the third nerve fiber layer in papilledema. And also, the OCT of the optic nerve head shows elevation of the optic disc. Well, this is a characteristic finding. It is a finger-like processes due to reflection by drusen in the OCT scan. And also here, we can see no separation between the sensory retina and the retinal pigment epithelium at the edge of scleral canal. In papilledema, you can see elevated disc, partially filled cup with separation of nerve fiber layer from the retinal pigment epithelium at scleral canal. So there is an obvious difference you can see here. So the difference between drusen and papilledema. So patient with drusen is a normal patient, vision is normal. Sometimes there is some visual field changes, but not affecting vision of the patient. and you give we need assurance of the patient, assure the patient, and give him a medical report to keep it with him for further examination or consultation for other doctors. In optic nerve tumor, you may find patient with elevated pigmented disc. So this is melanocytoma or elevated disc. Really, it's not elevated disc, but there is some tissue invading the disc. So this is astrocytoma. And this is some tissue invading the disc with hemorrhage. So this is leukemia, leukemic infiltration of the disc. So these are conditions of optic disc tumors, so congenital or acquired tumors. Of course, the patient's vision may be normal, may be affected here, some visual loss or visual field defects, or very poor vision in leukemia. What about pseudo elevation of the optic disc? These are conditions where the optic disc is elevated, but it's totally normal. In this patient, you can see here the plate margin of the temporal disc margin. So this is a crowded disc in hypermetropia. The disc is small and a lot of fibers, great number of fibers entering the disc. So the margin is elevated or blurred. So it looks like disc swelling, but it's normal disc. You can see this from the normal blood vessels, no classification of peripapillary nerve fiber layer. And the cup is seen here, small cup. Another condition, you can see blurred margin of the disc, and this is tilted optic disc. This is characteristic feature of this myopic patient. The characteristic feature of blood vessels, situs inversus, the blood vessels goes, the temporal blood vessel goes a little bit nasally before it reflects backward to the temporal side. So this is a tilted optic disc. The disc inserted in the globe, not at right angle, but is tilted. So this is a normal patient. Sometimes there is some visual field defect, but the vision is normal in most of those patients. So this is not a true optic disc swelling. Another case you can see here, feathery appearing area, white area near the disc is not extending from the disc, not disc edema or disc swelling. So this is some tissue or feathery-like appearance of the margin of the optic disc, and this will hide the optic, the blood vessels. So this is myelinated nerve fibers. This is a common condition. We all familiar of it. So this is not a true optic disc elevation. Another condition is the glial veil or glial tissue covering the optic disc. But you can see here, still seeing the well-defined edge of the optic disc, normal blood vessels. So this is the disc appearing here. The margin is ill-defined due to the glial tissue, but it's normal disc. So these conditions, these four conditions, hypermetropia, tilted optic disc, nerve fiber layer, myelinated nerve fiber layer, and the glial veil. These are four conditions. These are pseudo elevation of the optic disc. The disc is normal, but looks like elevated disc. Last group of the optic disc swelling, these are not true optic disc disease, but the primary disease is in the retina and choroid. And the diagnosis of these conditions is straightforward. By fundus examination, you can differentiate these conditions or diagnose these conditions. So we have here the bullseye of this picture is not the disc swelling, but the exudate macular star exudate with disc swelling, hyperemic disc. Here, hemorrhage plus disc swelling, vein occlusion. So this is a neuroretinitis, and this is central retinal vein occlusion. Here, there is hemorrhages, some exudates or cotton wool spots or infiltration with disc swelling. So this is leukemic infiltration of or leukemic retinopathy. Here, there is choroidal infiltrations, these white or yellowish areas, multiple choroiditis or inflammation of the choroid, and disc swelling. So this is multifocal choroiditis. Here we can see a lot of exudate, cotton wool spots, and hemorrhages, very attenuated arteries. So this is a case of hypertensive retinopathy. Disc swelling is secondary to this condition. You can see here sensoretinal detachment with hyperemic elevated disc. So this is a case of uveitis or Harada. This is swollen disc and low IOP. This is hypotony, and this is hypotony, swelling of the disc due to hypotony. So you have to also, this is important thing to check or measure the IOP in patients of disc swelling. So these conditions are primary disease of the retina and choroid associated with disc swelling, not real optic neuropathies. And the visual loss is not primarily due to optic disc swelling, but due to the primary disease of the retina and choroid. The home message for today: the optic disc may appear elevated while it is completely normal, as in pseudo-optic disc, as in drusen, as in hypermetropia. So this is a normal disc, but looks elevated. The important feature of the optic disc edema include opacification of peripapillary nerve fiber layer, as well as blurred margin and filling of the cup. So the very important feature here to differentiate between truly optic disc swelling and falsely optic disc swelling is opacification of nerve fiber layer. Of course, there are the other features, but this is one of the most important features. Although in most cases, we can rely upon fundus examination alone in differential diagnosis of optic disc swelling, yet specific workup may be needed to confirm diagnosis. Thank you. Any question?
Thank you, Dr. Abdullah. We will open now for questions. If there is anyone want to ask, please raise your hand. We have now Dr. Walid Tantawi.
السلام عليكم. السلام عليكم. اهلا بحضرتك. شكرا جزيلا يا فندم على المحاضره الرائعه. يعني تسمح لي اسال سؤال؟
اتفضل يا فندم.
يعني a lot of the time there is an overlap of symptoms between the different causes of true disc swelling. My question is, when do we need to send the patient for neuroimaging? Sometimes we are between the hammer and the anvil, أو زي ما بيقولوا بالعربي بين المطرقة والسندان. We don't want to miss a serious pathology, and in the same time we don't want to order expensive imaging. Also, يعني تكملة لهذا السؤال, when do we need to order CT versus MRI? And if we order an MRI, do we need to specify that it is a low cut scan or it doesn't matter? شكرا.
Okay, thank you. It's a good question. It is in all conditions we have what are the indication of neuroimaging in cases of optic disc swelling and also in pale optic disc. The history is very important. If we can find from the history, this is toxic history or ischemic history from the history, ischemic insult or toxic insult of the optic nerve no need to go for neuroimaging. But if we are expecting compressive lesion, intracranial lesion, orbital lesion, so we go for neuroimaging. In optic neuritis, we prefer MRI to see the enhancement of the optic nerve. We can, in brain tumors, we can go rapidly for CT because most of our hospitals, in most of them, we have CT, not MRI. So we can go for CT, and this could be enough in intracranial hemorrhage, intracranial space occupying lesion, and we can go after that for MRI. So this is the main issue. From the history, if it is ischemia or toxicity or in hereditary problem, in inheritance, if you have a congenital optic disc swelling, we go for neuroimaging once to rule out any intracranial pathology. But from the history, there is ischemia, or there is toxic, like in methanol toxicity, you can see pale swollen disc. So no need for further investigation or go for neuroimaging. But in other conditions, we have to go for neuroimaging, CT or MRI.
شكرا جزيلا. طب لو الاثنين متوفرين, is it okay that we order MRI for everybody instead of ordering CT?
It's better to go directly straight for MRI. يعني do MRI unless you don't have CT.
تمام. And if we order MRI, do we need to specify that's low cut or it doesn't matter?
Again, I don't.
If
you want to specify?
Do we need to specify that low cut scan or it doesn't matter?
I don't hear.
حضرتك تطلب MRI بتطلب standard brain and orbit, or do you write a specific instruction to?
You have to write if you are searching about some pathology in the optic nerve, expecting pathology in the optic nerve, you order MRI orbit and the brain with contrast fat suppression. You have to do fat suppression or fat saturation to see the enhancement of the optic nerve at the dark background, T1. But if there is no, because normally the MRI, the orbital fat is bright. So we need to suppress this bright signal. So by this procedure, our modality, fat suppression, we can see the enhancement of the optic nerve. So we order MRI orbit and the brain with contrast fat suppression. But if we expect stroke, space occupying lesion, intracranial lesion, hemorrhage, we go directly to MRI brain. No need for orbit study.
تمام. شكرا جزيلا دكتور عبد الله. شكرا. Thank you.
أهلا فندم. الله يخليك.
معنا دكتور أحمد عثمان.
السلام عليكم.
عليكم السلام ورحمة الله.
تفضل يا دكتور أحمد. عليكم السلام ورحمة الله.
Thanks, Dr. Abdullah, for this nice lecture and very important topic, and also confusing in the clinic. I have a few questions. The first was related to MRI brain. In cases of anterior ischemic optic neuropathy, I know that in all literature there is no MRI is ordered in such cases. But do we have to ask for MRI as a medical legal issue to exclude any other brain pathology? If there is any, usually they are old age, they may be associated with stroke, brain hemorrhage, or other brain pathology. Is it enough at a clinical and visual field diagnosis, or we should ask for MRI as a medical legal issue?
For ischemic optic neuropathy, I think no need to go for neuroimaging, because any intracranial lesion in the form of space occupying lesion or hemorrhage, subarachnoid hemorrhage, the patient must have some neurological deficit in the form of motor, sensory, autonomic, or cognitive changes. So we have this is for the neuro-ophthalmologist or the neurologist. We are familiar to see these neurological changes or deficits. So, on the neuro-ophthalmology field, no need to go for an ischemic optic neuropathy. We don't need to go for neuroimaging.
Or even neurological.
If you have a patient when there is a fear of intracranial problem, he should have some, if you have
some other clinical manifestation.
So you may have hemianopia, homonomous hemianopia, and this is easily detected by even confrontation visual field. No need to go for automated visual field. By confrontation, you can rule out hemianopia, homonomous hemianopia. So, in my practice, I don't need to go for neuroimaging and ischemic optic neuropathy.
Okay. The second question, Dr. Abdullah, sometimes you are facing two comorbidity. For example, a patient with optic disc drusen and papilledema on top. I faced one case like that. He was under treatment of benign increased intracranial tension, and he's coming for follow-up, and I was suspicious about optic disc drusen, and I did B-scan. I found it is an optic disc drusen, but he was under treatment already of benign increased intracranial tension. Sometimes
I saw some patient went for with disc with drusen. A few patients, it's not, I want to accuse our colleagues, neurologists, but some patients came from neurologists treated as underwent lumbar puncture and take the treatment of Diamox and medical treatment for high intracranial pressure. And they don't make lumbar puncture and measuring the opening pressure for them. Because in our country, many of the patients are reluctant to do the lumbar puncture. So they go blindly based on the papilledema of the disc and some visual field changes and some clinical data in the form of headache. Because many of our patients have headache in different areas. So he can correlate the headache with the swollen disc and treat the patient as high intracranial pressure or BIH. And I saw those patients, but for our protocol, we have to see the patient. If there is optic disc swelling and I'm not sure what this is, and sometimes really we have some difficulty in differentiating between true papilledema and drusen. It's not if you send the patient to ultrasound echography and the patient came without echo dense bodies in the optic nerve. So this is not rule out drusen, because this is due to if there is calcification within the drusen, it will appear echodense. But if there is no calcification, the optic nerve is seen elevated without this characteristic finding. So we go for OCT and measuring the nerve fiber layer. It's very sensitive. It could be normal or subnormal, there is thinning. But in true papilledema, it will be very thick. Right. Your question, I know your question are patient with drusen and papilledema.
How to make a definite diagnosis.
We go in our practice, some patient or few cases, we need to go for fluorescein angiography to see if there is autofluorescence of the disc and if there is leakage from the disc. In a small number of our patients, if we have a difficulty in diagnosing optic disc drusen and we are not sure of the diagnosis, we send the patient for fluorescein angiography to see if there is papilledema and leakage from the disc. So we can solve this problem and in our clinic, in an ophthalmology field, before going to the neurology. You can send the patient first, our protocol, send the patient first to ultrasound. If you cannot, if you don't see the classic picture of drusen in ultrasound, go for OCT to see the nerve fiber layer thickness and the shape of the optic nerve head. And then, if it's not conclusive, go for fluorescein angiography to see if there is leakage from the disc or autofluorescence.
Thank you, Dr. Abdullah. The last, very informative answer, Dr. Abdullah. The last one is related to the OCT differentiation between drusen and papilledema. You mentioned it before in the lecture. Can you repeat it for us, please?
Okay. I'll go to the picture. So
yeah, please.
My presentation.
Yeah, please.
Dr.
share screen يا دكتور عبد الله.
Islam.
share screen. share screen. سوري يا جماعة for the sound you are talking from the phone call فمعذرة إن الساوند لو مش واضح يعني.
فين شوف حضرتك هنا this picture. What are the characteristic features in this fundus picture? Number one, blurred margin. Both eye. Asymmetric swelling in most cases. Early branching of the blood vessels. Bifurcation or trifurcation. So this is no opacification of peripapillary nerve fiber layer. If we go with this small blood vessel, it is seen here at the edge of the disc. So there is no edema of the nerve fiber layer and the optic nerve disc. There is a lumpy appearance of the disc. This is one lump, two lump, three lump, third lump. So there is lumpy appearance of the disc. So this is characteristic for drusen, but sometimes it's difficult. It's not like this. And then we will go to this is the characteristic feature of echodense signal due to calcification. There is no calcification within the drusen, so it's difficult to see this fine. Then we'll go to the OCT, nerve fiber layer thickness, very thinning. As written in most of the text and the literature, there is thinning of the nerve fiber layer. But our series of patients, me and Dr. Sunil, my colleague in Bahrain Hospital, most of our patients with drusen are normal thickness, shows normal thickness. A study is, we are preparing a study that will appear, inshallah, after a few months to publish our finding in the nerve fiber layer thickness in Saudi people, in drusen. Because it's written in most of the sources, literature, that there is thinning of nerve fiber layer in drusen. But as we notice in our patient here in Saudi Arabia, most drusen cases present with normal nerve fiber layer thickness. Then, if you want to evaluate this nerve fiber layer in OCT, if you go with retinal pigment epithelial until the scleral canal, and then go with the sensory retina, there is no separation between sensory retina and retinal pigment epithelial at the scleral canal. In papilledema, you can see the difference. There is separation between the edema separates the sensory retina from the retinal pigment epithelium. There is an acute angle between the sensory retina and the retinal pigment epithelium and the scleral canal. And there is finger-like processes. This is what's called finger-like process appearance in the OCT. There is no finger-like processes here. I hope this can answer your question.
Thank you, Dr. Abdullah. Thank
you for this question.
Dr. Sari,
السلام عليكم. Thank you.
عليكم السلام.
اهلا وسهلا. ازيك يا استاذ؟
Thank you for this very nice lecture. I think one of the most confusing condition in the dyslipidemia is the optic disc drusen, as you mentioned. I think there is some rules to avoid sending the patient for more expensive investigations before knowing what is the condition. First, I think the consultation of both the retina and the glaucoma unit, because they are the most familiar doctors to see the optic nerve every day, and they are the most able to have any subtle change in the disc they can detect. Number two, before sending the patient from the ophthalmology service, as you mentioned, they can do ultrasound, and also fundus autofluorescence optic disc drusen can appear in the fundus autofluorescence. And one most important thing is if you are very in doubt with the diagnosis and the condition like this, there is no hemorrhage on the disc, there is no vessel tortuosity, there is no headache, severe headache, or the signs of emergency, you can follow up the patient simply, and you can tell the patient to come after 1 week after having fundus photo. And if the progression is the condition is progressive, you will see the progression. This to avoid, as Dr. Walid Tantawi said, to avoid sending the patients for expensive investigations, and then at the end the patient is normal. This is just to highlight this protocol, something like protocol to deal with these patients in the ophthalmology service before even telling the patient there is a very big condition, or the patient will be worried, and some doctors tell him that they may be a tumor in the brain, and the patient is afraid from this. It's simple to make these rules before telling the patients anything yet.
Thank you, Dr. Sari, for this valuable comment. But you have to send the patient to retina doctor. Being a retina consultant, we have to send the patient to retina. Very good comments. Okay.
دكتور محمد حيدر.
تفضل دكتور محمد.
السلام عليكم دكتور عبد الله، ازي حضرتك؟
عليكم السلام ورحمة الله، أهلا وسهلا.
Thanks so much for this informative lecture and very important topic. I am asking about post-papillodemic optic nerve gliosis, and the patient may experience again elevated in the intraocular pressure, intracranial pressure, I mean. What could we do to know if the patient is suffering from another increase in intracranial pressure? Is it imaging or something else?
What is the problem of post? I'm not understanding the question. If the patient has papilledema and gliosis and pallor, what is what you want
if the patient experiences again another increase in intracranial pressure, this will not appear in the optic disc head as a papilledema again, as we know from.
Yes.
How could the ophthalmologist tell that there is another increase in intracranial pressure again?
Okay, this is based on two things. The first one is the clinical picture, headache, nausea, vomiting. The second thing is lumbar puncture. We cannot know anything about the level of the intracranial pressure unless we do the lumbar puncture. We can send the patient again to a neurologist or an anesthesiologist to do the lumbar puncture and come with the report. If the patient, this happened with our patient for benign intracranial hypertension or idiopathic intracranial hypertension. Those patients this is a chronic disease. You are seeing the patient from the beginning of papilledema, and then they may end by some sort of partial optic atrophy. We treat them medically. Those patients are classified in two categories. If the patient has severe headache, not improving by medication, and the vision is good, we can start with the medical treatment. If there is severe headache and some neurological problem, we send the patient for neurology to do the shunt. If there is rapid deterioration of vision and visual field, we do the optic nerve sheath fenestration. All these procedures done after giving the medical treatment of the patient. With long history, some patients are experiencing they have persistent headache. And this could be due to high intracranial pressure. There is no other mean to know there is high pressure until we send the patient again to do lumbar puncture and see the opening pressure. So this depends on the medical condition or the clinical picture. There is headache, persisting headache, nausea, vomiting, or we can send the patient. If we see deterioration of the visual field, we have to send the patient to do lumbar puncture, and he may go for shunt surgery.
Okay, thank you, sir. Thank you.
Welcome.
Dr. Kasper?
Yes. Thank you.
You're welcome.
Thank you, sir, for this
Welcome.
lectures. My question is there a complete resorption or resolution of disc swelling or papilla edema if the cases of toxic insult or ischemic insult or even hypertensive papillopathy? And will the nerve return to normal looking or go to the pillar stage or atrophy? Thank you.
Okay, this is a question or comment on the. Okay.
Question, sir. Question, sir.
Question.
So I don't understand your question. This is the patient with swollen disc and by optic atrophy. What's your?
Is there complete resorption, complete resolution of disc swelling if we treated the patient urgently, quickly, especially in cases of toxic insult, ischemic insult, and the nerve, the looking of the nerve, return to the normal looking or go to the pillar or atrophy even we treated?
Yes. Okay, a good question. This depends on the extent of damage of the optic nerve caused by this papilledema or disc edema. We can differentiate between different pathologies. In papilledema, the vision will not affect it unless the patient is chronic and after several months, the vision deteriorates. But this is not unlikely or it's not the case in cases of optic neuritis or ischemic optic neuropathy, because the pathology is different. This is a stroke of the optic nerve or inflammatory process going on the optic nerve and optic neuritis. So this will damage the optic nerve cells or fibers from the beginning. So this will lead to pale optic disc or optic atrophy, partial or total optic atrophy. These are seen in optic neuropathitis, ischemic optic neuropathy, the traumatic optic neuropathy, compressive optic neuropathy. This depends on the extent of damage of the optic nerve or the fibers that are damaged from the optic nerve. In papilledema, the visual loss or visual field problem will occur after long time because there is no actual damage of the optic nerve. There is stagnation or slowing of the exoplasmic flow through the optic nerve axons. It will take time to shift or to go to the damage in metabolism and degeneration of the optic nerve cells and then pallor of the optic nerve.
Okay, دكتور محمد سيد.
السلام عليكم.
دكتور محمد اتفضل.
سؤال بسيط. عندنا هنا في المنطقه الجنوبيه في مشكله ان بنشوف توكسيك اوبتيك نورايتس كتير في الشباب بالذات نتيجه القات والبيشنت ديناي.
نتيجه ايه حضرتك؟
القات يا دكتور.
القات في اليمن
في المنطقه الجنوبيه هنا.
المنطقه الجنوبيه. طيب اتفضل.
البيشنت ديناي تماما، لان في ساعات بيبقوا عسكريين او في الشرطه بينكر تماما ان هو تمام، واحنا مش شايفين اي سبب لذلك. ثانيا في بعض الناس بيشربوا الكحول، وفي ستاديز بتقول لو لقيت واحد نتيجه الالكحول او القات نعمله هيموداياليسيس ممكن يعمل رابد ريهابيليتيشن للفيجن. الكلام ده ايه راي حضرتك فيه؟
هو في الميثانول يعني توكسيسيتي the prognosis is very poor. يعني انا شفت مرضى several patients with methanol toxicity at the same day or the next day there is totally loss of vision to no PL or hand motion or even PL and vision will not improve. And the fundus shows swollen pale disc in both eyes with characteristic findings, not the optic disc only swollen, the nerve fiber layer along the blood vessels, the temporal arcades mainly. There's swelling of the optic disc and also swelling and pallor of nerve fibers along the arcades, the vascular arcades. So this is characteristic for ischemic optic neuropathy, and this is ends by severe pallor and cupping. Also, I noticed is severe cupping with the disc after that. For this is concerning methanol. If the patient don't give the history or refuse to or deny that this history, it's not our problem, but we expect this, and we from my experience, don't ask the patient directly because he don't ask the patient in front of his relative, his father, his
I know.
You have to talk with the patient separately alone and tell him this is a dangerous condition. You have to tell us to give you the proper treatment. You will lose vision, and he will give
job
you the
also lose his job كمان.
This is if the patient doesn't give the history, but you are expecting the toxic optic neuropathy. It is a bilateral, nearly symmetric. If it's not complete, so you can see the visual field. It could be central or secocentral scotoma if the vision is relatively good. But I don't know about cut. I don't know the pattern of visual field loss. But I saw many patients of methanol toxicity.
Okay, iPhone. We have 3 questions more, so it's okay for you, Dr. Abdullah.
تفضل يا فندم.
iPhone.
السلام عليكم.
عليكم السلام ورحمة الله.
وعليكم السلام ورحمة الله.
أحمد وجدي يا فندم مع حضرتك. Thank you very much for this very nice presentation. شكرا أستاذ مزاحات. Dr. Abdullah, please, I have one question. When do I need to order an MRI with contrast and an MRI with no contrast?
Okay. It's better to do MRI with contrast in all conditions. Because the pathology, any type of pathology will enhance with contrast. We can diagnose intracranial or optic nerve problem without contrast from diffusion, like in MS without contrast. In MS, it will appear, and T2 shows it will without contrast. It will appear in flare scans without contrast also. But it's better if whenever you do the MRI or order MRI to order it with contrast.
Regardless of the general,
Because if you go to any textbook of radiology or neuroradiology, you will see all condition in MRI. You will see all the pathologies. They explain it or describe it as this is the T1 without contrast, T2 and T1 with contrast. There are specific features for these, like in Masalan, for example, in case of meningioma. The MRI of meningioma, it is iso-intense in T1, so intense and enhanced with contrast. Iso-intense means like the brain tissue, the meningioma will appear in T1 as brain tissue, the same intensity, and T2 as the brain tissue, and enhanced with contrast. So this is, it is diagnostic issue for the radiologist to make the study, full study with, should be ordered with contrast. to diagnose the pathology of specifically.
دكتور عمرو زيادة.
Regardless of the general condition of the patient, Dr. Abdullah, because as you know, sometimes the patients are elderly and having some like renal problems and renal issues or something like this. Does not carry some medical legal aspects if I ordered in contrast with all patients?
Okay, if there is real contraindication, you can do without contrast.
Yeah.
This is a rule of, there are limitations of our investigation. All investigation has some limitation. If you cannot do the test with contrast and go full details of the diagnosis, at least we take an idea about the pathology. Do it without contrast.
Thank you very much. I have one more question, please, if you can allow me, Dr. Abdullah. I know from a residency period that if I'm doing B-scan ultrasonography to rule out the risk erosion, I should be lowering the gain, like 40 to 45. Is this correct?
Okay. Yes, that's right. As a rule, all the bright signals in the ultrasound reduce the gain to see properly. All the low reflective findings in the eye, you have to raise the gain, like in vitreous opacities. If you want to see the hemorrhage, so raise the gain to see the hemorrhage. Astigmatic hyalosis, they are high reflective particles, so decrease or lower the gain to see it properly. Retina and choroid, reduce the gain to see details in the retina and choroid. So this is the rule of highly reflective structures reduce the gain to see the details. Low reflective structure increase the gain to see the details.
Thank you very much, Dr. Thank you very much. Very important.
السلام عليكم دكتور عبد الله. معك دكتور عمرو زيادة.
السلام ورحمة الله. أهلا يا أستاذ.
Thank you so much for the very nice lecture. Actually, I want to ask about some cases of consecutive optic atrophy due to papilledema. Sometimes we encounter with like borderline IOP. Is it advised in these cases to give IOP lowering medications, and is there a relation between the papilledema and this increase?
IOP, intraocular pressure or intracranial pressure?
Intraocular pressure. Intraocular pressure.
There is a papilledema with high intraocular pressure. I don't know. And you want to
like borderline, like 19, 20, like this.
With papilledema, a patient with papilledema, and the IOP is around 20.
Yes, yes.
You want to give him some lowering, some anti-glaucoma medication to lower the IOP?
Is it advised, or what are the indications for this?
I don't know. You read this about this? I don't know about this, but it could make sense because this can affect the autoregulation of the optic nerve head. If you reduce this is the reverse. This is in hypotonia. In hypotonia, you have a relation between the intracranial pressure and the intraocular pressure. They are counteract each other. This is the pathophysiology of the optic disc swelling. If the intracranial pressure increases with normal IOP, so the disc will swell. This is the case of papilledema due to high intracranial pressure. If the intracranial pressure is normal and IOP is lower, very low, so this will shift the condition, and the disc also will swollen. So normal disc means there is some relation, equilibrium between the intracranial pressure and intraocular pressure. So it makes sense if you give lowering, if you lower the IOP, this will deteriorate or increase papilledema.
Okay, Dr. Muhammad Shaheen. Dr. Muhammad Shaheen. Dr. Muhammad Shaheen.
السلام عليكم. السلام عليكم، متشكرين دكتور عبد الله على المحاضرة الجميلة. هو أنا بس ليا سؤالين بصراحة. بالنسبة إزاي هل في ممكن أفرق بحاجة واضحة في الفلوريسين ما بين الانتيريور اسكيميك اوبتيك نيوروباثي اند بابيلايتس من ناحية الفلوريسين؟ والسؤال الثاني، اخد رأي حضرتك في حالة ان كانت فيميل حوالي حاجة و20 سنة، وهي جاية ببليرنج وفيجن فيها 6-9، كان يونيلاترال اوبتيك ديسك سويلنج، والسي تي بتاعها بارشال امبتي سيل تيرسيكا، وما كانش اي في بوزيتيف داتا ثانيه موجوده، فدي كان ممكن نتعامل معاها ازاي؟ شكرا.
الاول اللي هو how to differentiate between bifluorescein and geography. First of all, I like to say that the fluorescein angiography is not a standard test for papilledema. It's not a standard for papilledema, so we'll not order fluorescein angiography in all cases of papilledema. Second,
in case of papillitis,
in optic, in ischemic optic neuropathy, we are not requesting fluorescein angiography in ischemic optic neuropathy. But if we do fluorescein, sometimes we request fluorescein angiography in arthritic ischemic optic neuropathy to see the specific sign, choroidal non-filling or ischemia, patchy non-filling the choroid, before going to temporal artery biopsy, because this is more invasive procedure. We can do the fluorescein angiography. And you have the clinical picture of the giant cell arthritis. You want to be sure to confirm your diagnosis, go for fluorescein angiography and see if there is some choroidal ischemia, patchy ischemia of the choroid. And this is also another positive data added to your diagnosis of anti-arthritic ischemic optic neuropathy. But fluorescein angiography in non-arthritic ischemic optic neuropathy, you can see very early sectoral non-filling of the sectoral non-filling of the optic nerve head. يعني احنا عندنا بيبقى في sectoral pallor في ischemia of the optic nerve head. You can detect that in fluorescein very early picture. Because the affected part is the pre-laminar optic nerve. The stroke occurs in circle of Zen in the pre-laminar optic nerve. There is a partial occlusion or stroke, small stroke of the optic nerve head in the pre-laminar area. So this is a choroidal circulation. You can see the choroidal circulation very early in fluorescein. You can see ischemia or non-filling of a part of the optic disc. And fluorescein angiography, but we don't do this regularly. Better we do the visual field, and clinically, based on the clinical data, visual field altitudinal defect in many cases, but could not be altitudinal defect, central scotoma or other pattern of visual field loss. But in most of cases, we see the altitudinal defect in the visual field.
دكتور أيمن عوض.
السلام عليكم، مساء الخير. Thank you, Dr. Abdullah, for this nice lecture. I have one question, Doctor. I face usually many cases of idiopathic intracranial hypertension. For these cases, I need to know the protocol. Is there a protocol for treatment? Usually, I start them with acetazolamide, and usually they are improving well with this drug. But for how long? And should I stop it at once, or I stop it gradually as we do with steroid? Is there any protocol for treating idiopathic intracranial hypertension before we are going to the surgical procedures? I'm talking about the acetazolamide mainly. Is there any protocol to use it, for how long, and the dose? Thank you. This is my question.
Okay, welcome. As I said before, the BIH or IIH, idiopathic intracranial hypertension, is a chronic disease. There is a multifactorial disease, or many factors affect the pathology of the disease. Could be hormonal disturbance of the patient. The most important is the obesity of the patient, female. And also could be some anatomical abnormality in the venous sinus in the brain, some narrowing of the transverse sinus, or sigmoid sinus or in the brain. Many causes or factors can affect the etiology. But the mainstay of treatment is the diamox to decrease the intracranial pressure medically with diamox or carbonic anhydrase inhibitors. We give 1 gram. We have to go parallelly with diamox and weight reduction. Weight reduction is very important as well as the medical treatment. If the patient can reduce her vision by her weight by 6 to 10%, she will benefit from this weight reduction, maybe more than the medical treatment. So ask the patient to control her weight if she is overweight by 6 to 10%, and then give Diamox 1 gram to 2 grams per day per kg body weight, up to 1.5 milligram per kg or 2 gram per kg. 1 to 2 gram per kg body weight. And then for how long it will take several months. Many patients will a few weeks and others will take several months. You can follow up the patient and don't go for further surgical intervention unless there is rapid deterioration of the visual field. We'll go to the optic nerve sheath fenestration or severe neurological problem. We send the patient for shunt surgery.
Okay, our last.
Of course, we have to follow up the patient to see if there is any deterioration of his renal function.
Thanks, Dr. Abdullah. Our last 2 questions from Dr. Magdi Afifi and Dr. Ahmed Labib. So, Dr. Magdi, تفضل.
تفضل يا فندم.
عليكم السلام ورحمة الله وبركاته.
Thank you very much, my prof. Dr. Abdullah هو أستاذ
الله يخليك. أهلا وسهلا.
Just I have a comment to Dr. Abdullah. Can you give me a chance to get? True optic disc swelling can occur without any symptoms can occur at any age. So it is important to examine every patient, even the cases come from routine examination, like making glasses, whatever the age. In the last few months, I see 2 patients. One was 10 years old, the other boy was 12 years old. They just coming from glasses. And when I look at the fundus, I find optic disc swelling, and the 2 cases was BIH. So it is important for every one of our colleagues to stress on examination of the optic disc in all cases, especially the routine cases. This is my comment, and thank you very much, Dr. Abdullah.
Very, very important notes, Dr. Magdi, لأنه you are, as you are mainly a pediatric ophthalmologist, you are concerned about screening of all kids so it's very important to look to the fundus in all patients. Okay.
Dr. Ahmed Labib.
السلام عليكم دكتور عبد الله.
السلام ورحمة الله. أهلا يا أستاذ. أهلا وسهلا.
ازيك؟ معلش انا تابعت المحاضرة بتاعتك طبعا وانا كنت سايق، فيعني في اجزاء منها يعني اي ميست، فما اعرفش انت يعني في ثنايا المحاضرة
بيحطوها بتهيألي على اليوتيوب. اسلام بينزلوها بتهيألي.
موجودة على اليوتيوب.
هو بس السؤال بتاعي ماشي. انا بس لو الحته اللي انا يعني عايز اسال عليها الجريدنج او السكيلينج بتاعه البابيليديما، انا مش فاكر اسم الجريدنج ده كان ايه، بس هل انت ذكرتها في المحاضره وانا ما سمعتهاش ولا ما تعرضتش ليها يعني؟
طيب في سؤال تاني ولا الجريدنج؟
لا هو ده بس.
الجريدنج انا الحقيقه حتى مش فاكرها وما ببصش فيها لانها not حاجه theoretical rather than practical or clinical. It's not.
هي clinical grading.
Our professor in US, our trained Bascom Palmer, they don't use any grading for papilledema, just to diagnose papilledema. To differentiate papilledema from drusen, it's a very practical and clinical issue because this will affect the management and treatment. to differentiate between early, established, and late papilledema. Early means swollen hyperemic disc with relatively good function of the visual potential. Established papilledema, this means that complete disc swelling with hyperemic disc, tortuous vessels, some hemorrhage and exudate, and still there is mild or moderate affection of the function of visual function. Late papilledema means atrophic sheath vessels, atrophic disc with poor vision. So this is not, in my opinion, is not a practical issue or clinical issue in managing the patient.
تمام. ماشي يا دكتور. شكرا يا دكتور.
شكرا يا فندم.
شكرا يا دكتور عبد الله. يعني احنا اعتقد جاوبنا على معظم الاسئله حتى اللي كانت موجوده في الشات، معظمها كان بيدور على نفس الكلام اللي اتسال يعني. فاحنا طبعا بنشكر الدكتور عبد الله شكرا جزيلا، وربنا ينفع بيك وبعلمك يا رب ويجعله في ميزان حسناتك. ثانك يو دكتور عبد الله
سعيد بالمشاركه ونشوفكم دايما ان شاء الله بخير.
ان شاء الله. الله يكرمك يا دكتور عبد الله.
Thank you.
جزاكم الله خير. Thanks دكتور عبد الله for this nice lecture, and we are planning tomorrow for having Dr. Khalid Hassan. He will talk about management of coexistent cataract and glaucoma. Our timing will be at 7 p.m. Saudi Arabia local time, or 6 p.m. Cairo local time. Tomorrow we will have a very nice, informative, inshallah, meeting. And all our videos, as we know, is on YouTube channel, our online OFSA, and on Telegram channel, also online OFSA. We have a lot of presentations in the next coming days and a lot of starts in next week. So thank you, and hope that you enjoy our lecture today, and hope to see you tomorrow inshallah. نراكم على خير، ونلتقي إن شاء الله بكرة بمشيئة الله سبحانه وتعالى في نفس موعدنا الساعة 7 بتوقيت السعودية، 6 بتوقيت مصر إن شاء الله. السلام عليكم ورحمة الله وبركاته.
عليكم السلام.